My name is Oriana Lowe, and I am a pediatric dentist from Los Angeles, California. Today, I will be talking on pharmacological considerations of behavior management in pediatric dentistry, Part 2. This section will cover oral sedation, intramuscular sedation, IV, and general anesthesia, commonly used drugs for sedation, and monitoring devices used during the sedation process. We'll begin by talking about oral sedation. Oral sedation is the most universally accepted and easiest method of drug administration. Administration is the most variable. This method is dependent on absorption through the gastrointestinal mucosa. The drugs are administered by mouth, vary in peak, and are consistent of effect. The reversal of any unwarranted effect is also difficult. The operator cannot titrate this drug to achieve optimal effects with moment-to-moment controls as with other methods. Recovery time may be prolonged because the drug is slowly metabolized. Many practitioners attempt to overcome the problems of length of onset by having the parent administer medications at home. This, however, is not a common practice today. It was so 20-25 years ago when we would ask the parents to administer medication for the child at home before they came to the office. Except for minor tranquilizers such as diazepam and hydroxyzine, all other sedative agents should be administered in the office by trained personnel. After the sedative agents have been selected, the proper dose of the medication is calculated for the child, keeping in mind the maximum recommended dose of each agent. When the desired effect is observed, usually after a period of 30 to 60 minutes, the patient is transferred to the operating area and placed in the chair. For small children or children who may become physically combative, using a reclining restraint is advisable. The arms, legs, and mid-body should be secured. However, the chest and diaphragm must not be restrained to avoid obstruction of respiratory muscles. A shoulder roll is suggested to be placed to keep the head slightly rolled up and back to allow for more patent airway. Nitrous oxide oxygen may be started at this time for added effect as well as for oxygenation. If the patient is not adequately sedated to the point that treatment can be accomplished, the attempt should be aborted and considered a sedation failure. The patient should be reappointed for another attempt in which either the dose or the technique is altered. It must be known that increments of medication should not be administered to avoid the risk of an overdose, which is caused by variable and unpredictable absorption. Titration is dangerous and should be reserved for intravenous techniques that do not rely on variable absorption. The patient should be monitored carefully. Discharge to the parent should occur only after minimal discharge criteria have been met. Full oral and written instructions on post-sedation care should be carefully reviewed with the caregiver and written information given to that person for easy reference at home. Oral sedation may be achieved by using a combination of various drugs. Intramuscular sedation is another sedation technique. Parenteral administration of drugs for sedation requires additional training and skill. Intramuscular injections, when used, the anatomy of the injection site and the different pharmacological effects of the drugs to be used must be considered. It is not usually preferred over the oral route by the pediatric patient, especially those in the younger age group. Oral and intramuscular sedation share common problems. Prolonged time required to reach peak effect, although it is shorter than with the oral route, and the variability and unpredictability are seen in onset and in effect. The lack of total reversibility, except in the case of the narcotics used, once the drug is deposited in the muscle mass, the operator must be prepared to watch for any drug activity and to work to reverse that effect if possible. The injection site selection is a very important aspect of intramuscular drug administration. The vastus lateralis muscle on the anterior thigh is the safest for small children. This is a rectangular area over the lateral aspect of the thigh, and I will have a picture to show you this on the next slide. The upper outer quadrant of the gluteus maximus muscle in the middle of the posterior lateral aspect of the deltoid is also another preferred site. Once the medication has been injected, if the desired effect is not achieved in a reasonably expected time of 20 to 30 minutes, either the treatment should be performed under existing circumstances or the patient should be given a reappointment, at which time either an increased dose or an alternative method of sedation is used. And here are the photos, the outer lateral portion of the anterior thigh on the lower picture and the deltoid muscle on the upper portion of the thigh are usually the preferred methods. Submucosal sedation is another form of sedation that's used. It involves the deposition of the drug beneath the mucosa. This site usually is chosen for injection is the buccal vestibule, particularly in the area of the maxillary, primary molar, or canine. The term submucosal is often used interchangeably with subcutaneous. This usage may be erroneous because research has shown the serum level of a drug to rise very quickly after injection into the vessel-rich areas just described. The response time probably should be considered to be somewhere between those of the intramuscular and the intravenous administration of a drug. Next, IV sedation. Sedation levels in which the patient remains conscious are readily achievable through the use of IV techniques. In the hands of properly trained professionals, this method can be the easiest, most efficient, and safest next to sedation by inhalation. The use of IV conscious sedation in pediatric dentistry is somewhat restricted to certain types and ages of patients. Venipuncture is difficult to accomplish in the very young or the combative child. Such difficulty is attributable to smaller vein size and availability together with the need to restrain the patient. This technique is more suitable for the apprehensive preteen and adolescent patient. The onset of action of the drug is between 20 and 25 seconds, which is the most rapid among all the techniques. Thus, the opportunity to render the patient unconscious and unintentionally is much greater. A practitioner with limited training in management of the airway or of the unconscious patient should never consistently crowd the line between consciousness and unconsciousness. That's dangerous. The possibility of phlebitis is also a disadvantage, particularly with drugs that are insoluble in water. Hematoma at the site of venipuncture is a complication, but it does resolve. A mention about the sedation technique. The dose-response relationship is a graded dose of drug regimens in a larger magnitude of response as the doses increase. As the doses increase, the variability in limiting the ability to predict response is increased. Reliance on monitoring devices and high levels of anesthesia training and the ability to manage adverse events can be problematic. Resuscitation by highly trained dental teams in a hospital setting may not be sufficient. And the trained teams must be consisting of medical personnel, including physicians and nurses. Basically, there are two techniques used for IV sedation. The first employs a simple single drug, usually a benzodiazepine, whereas the second requires a sophisticated combination of several drugs, usually including a narcotic. The single drug technique is probably the most adaptable to a pediatric practice, and unless extensive training opportunities exist, the multiple drug method should not be considered. Facilities and equipment. The facility should also be equipped with adequate suction monitoring devices and a positive pressure oxygen delivery system capable of sustaining greater than 90% oxygen at a flow rate of 10 liters per minute for at least 60 minutes. One 650-liter e-cylinder must be available. When a self-inflating bag valve mask device is used for delivering positive pressure oxygen, a 15-liter per minute flow is recommended. A functioning suction apparatus with appropriate suction catheters and a phygmomanometer with cuffs of appropriate sizes for pediatric patients must be immediately available. A crash cart should be on site and carry the recommended drugs. Some of the drugs that the crash cart should have within it is albuterol for inhalation, ammonia spirits, atropine, diphenhydramine, diazepam, epinephrine at 1 to 1,000 or 1 to 10,000, flumazenil, glucose, lorazepam, oxygen, fosphenytoin, rocuronium, sodium bicarbonate, and succinylcholine. These are some of the most important drugs that we must have on the crash cart. Commonly used agents for sedation in addition to the drug medication is oxygen and nitrous oxide. Together we have nitrous oxide oxygen. Now we will talk a bit on antihistamines. Antihistamines that are commonly used include hydroxyzine, better known as Atarax or Vistaril, which is rapidly absorbed from the GI tract. Clinical effect is seen in 15 to 30 minutes with peak levels at 2 hours. Administration is preferably by the oral route. Adverse reactions include extreme drowsiness, dry mouth, and hypersensitivity. The dose is usually oral, 1 to 2 milligrams per kilo. If you dose it intramuscularly, or the IM injection, 1.1 milligrams per kilo. It is supplied in as Atarax tablets, 10, 25, 50, and 100 milligrams, or in Atarax syrup, that's 10 milligrams per 5 ml. Vistaril is available in a suspension at 25 milligrams per 5 ml, and also it is injectable at 25 or 50 milligrams per ml. To calculate the dose needed, if you're using Atarax at 10 milligrams, you have a 3-year-old child at 40 pounds. So you must first convert the pounds to kilograms. And the dose of the Atarax is represented in milligrams per kilo. So the sub-Q method is not recommended. Maximum recommended single dose is 25 milligrams. It is supplied in tablets at 12.5, 25, and 50 milligrams. The syrup is supplied in 6.25 and 25 milligrams per ml, and the injectable is 25 and 50 ml per milliliter ampules. Calculating the dose using a 25 milligram per 5 ml suspension of Vistaril for a 3-year-old child weighing 40 pounds. Again, you need to convert the 40 pounds to kilograms. Now, a word on Phenergan or promethazine. It has sedative and antihistaminic properties. It is well absorbed after oral ingestion. Onset is within 15 to 60 minutes with a peak at 1 to 2 hours and a duration of 4 to 6 hours. Phenothiazines should be used with caution in children with a history of asthma, sleep apnea, or a family history of sudden infant death syndrome. Phenothiazines lower the seizure threshold and should be avoided in seizure-prone patients. Interactions, it potentiates other CNS depressants. Adverse reactions include dry mouth, blurred vision, thickening of the bronchial secretions, mild hypotension, and extrapyramidal effects. The dose is orally or IM 0.5 to 1.1 milligrams per kilo. Sub-Q method is not recommended. Maximum recommended single dose is 25 milligrams. Supplied tablets you'll find at 12.5, 25, and 50 milligrams. The syrup form is available at 6.25 and 25 milligrams per ml. The injectable form is available at 25 and 50 milligrams per ml ampules. Now we'll talk about Benadryl and diphenhydramine. An antihistamine with sedative properties is this drug, rapidly absorbed through the GI tract with a maximum effect in 1 hour. The duration of effect is 4 to 6 hours. Diphenhydramine is metabolized by the liver and completely excreted in 24 hours. It produces a mild sedative effect, but has additive effects with other CNS depressants. The adverse effects include disturbed coordination, epigastric distress, thickening of the bronchial secretions. Doses of diphenhydramine, oral or IM or IV, is 1.0 to 1.5 milligrams per kilo. The maximum single dose is 50 milligrams. It's supplied in a tablet form at 50 and 25 milligrams. The elixir is available at 12.5 milligrams per 5 milliliters. The injectable form is available at 50 grams per milligram. Now we will speak about benzodiazepams. Benzodiazepam is, one form is Valium, a benzodiazepam that is lipid soluble and water insoluble. It is rapidly absorbed from the GI tract, reaching peak levels at 2 hours. The biotransformation of the drug occurs slowly, and it has a half-life of 20 to 50 hours. The drug has 3 active metabolites, one of which is very lipophilic and has a half-life of 96 hours. These metabolites are more anxiolytic than sedative. After intravenous administration, diazepam is redistributed within 30 to 45 minutes, and the patient seems not to be sedated, although free from anxiety. The patient should not be considered recovered from the drug. It has simply been redistributed. Diazepam has a rebound effect. The stored drug can be redistributed to the CNN by a fatty meal consumed sometime after the patient has been sedated and left the office. Suddenly, the patient will feel resedated. So we should avoid giving someone that has had Valium a fatty meal after being sedated. Diazepam is a strong anticonvulsant. It can be administered orally, rectally, or parenterally. Ataxia and prolonged CNS effects are the only common adverse reactions that can be anticipated when diazepam is used for conscious sedation. The dosage, oral or rectal, is 0.2 to 0.5 milligrams per kilo to a maximum single dose of 10 milligrams. Supplied IV or injected IV, it's 0.25 milligrams per kilo. It is supplied in tablets at 2, 5, and 10 milligrams, and the suspension is available at 5 milligrams per ml. Versed is another drug that is commonly used. It has a higher water solubility than diazepam. The possibility of thrombophlebitis is reduced to a minimum because of this characteristic. Midazolam is packaged in an acidic solution of pH of 3.3, a state in which the drug is water soluble. After IV administration, sedation occurs in 3 to 5 minutes. Recovery occurs in 2 hours, but is variable and may require up to 6 hours for complete return to baseline values. There is no rebound phenomenon from metabolites. Midazolam can also be given effectively intramuscularly. Midazolam or Versed is available orally as a syrup. 50 to 65% of the oral dose will go through first pass hepatic metabolism. The onset of action orally is between 20 and 30 minutes with an elimination half-life of 1 to 2 hours, which provides approximately 30 minutes of working time. Oral administration is indicated primarily for anxious patients requiring relatively short dental procedures. Versed may produce respiratory depression with higher doses. There is a dose-related risk of apnea, which is believed to be influenced by the rapidity in which the drug is administered. Apnea is more likely to occur when midazolam is used with narcotics. Hypotension also occurs more frequently with this combination. Doses should be adjusted downward when midazolam is used with any other CNS depressant, especially the narcotics. These effects are not usually seen if the drug is appropriately titrated. Compared with diazepam, midazolam produces better analytics and amnesia. Between 75 and 90% of patients will experience retrograde amnesia for up to 4 hours. Midazolam is 3 to 4 times more potent than diazepam, and it has twice the affinity for the benzodiazepam receptor. The doses for Versed, the oral dose is 0.25 to 1 milligram per kilo to a maximum dose of 20 milligrams. IM injection is 0.1 to 0.15 milligrams per kilo to a maximum dose of 10 milligrams. The IV way is slow titration. You must see the manufacturer's recommended dosage. When it's supplied as a syrup, it's 2 milligrams per ml, and in the injectable way is 1 milligrams per ml or 5 milligrams per ml vials. Now a word about the benzodiazepine antagonists. The antagonist includes romazicon or flumazenil. It is a benzodiazepine receptor antagonist. It has been shown to be effective in reversing the sedative effects, but not necessarily the amnesic or anxiolytic qualities of benzodiazepines. Induced seizure activity will occur in patients receiving benzodiazepines for control of convulsive disorders when flumazenil is used. The drug is recommended for IV use only and is not recommended for use in children younger than 18 years of age. For reversal of conscious sedation, the initial dose should be 0.2 milligrams given over 15 seconds. If needed, another dose of 0.2 milligrams should be administered and dosing repeated in 60-second intervals to a maximum dose of 1 milligram. Most patients will respond to doses in the range of 0.6 to 1 milligram. And the onset of reversal is usually seen within 1 to 2 minutes. It is supplied in 5 and 10 ml multiple use vials containing 0.1 mg per ml in boxes of 10. Barbiturates. What are barbiturates? Barbiturates can produce all levels of CNS depression, ranging from mild sedation to general anesthesia and deep coma. Chlorohydrate, also known as Noctic and aquachlorosuprets, is an extremely well-known and widely used drug for pediatric sedation. It has an onset of 30 to 60 minutes when given orally. The duration of action is between 4 and 8 hours and a half-life of 8 to 11 hours as a result of the formation of active metabolites. The primary metabolite of chlorohydrate is trichloroethanol, which is responsible for most of the CNS effects that occur. Chlorohydrate is irritating to gastric mucosa, and unless diluted in a flavored vehicle, will frequently cause nausea and vomiting. And the children usually do not like to take this as a drink. Large doses also depress the myocardium and can produce arrhythmias, and thus should be avoided in patients with cardiac disease. The lethal dose of chlorohydrate is stated to be 10 grams in adults, but yet ingestion of 4 grams has caused death in some individuals. The dosage must be individualized for each patient. It is recommended use is 25 to 50 milligrams per kilo to a maximum of 1 gram. It is supplied in oral capsules of 500 milligrams, and oral suspension 250 and 500 milligrams per 5 ml, and rectal suppositories are also available. So we come to narcotics. Narcotics are the heavy artillery of pediatric conscious sedation. They are not employed with any great consideration for their analgesic properties. They do produce sedation and euphoria to a greater degree in children than in adults. A significant drug-drug and drug physiologic interaction can occur when narcotics or other drugs that depress respiration are combined with local anesthetics. In usual doses, local anesthetics are CNS depressants and will provide additive depression when combined with other CNS depressant drugs. Lidocaine toxicity will result in CNS excitation and seizures, and ultimately in coma and death. Sedative hypnotics includes Demerol or meperidine. It is meperidine should be used with extreme caution in patients likely to accumulate or be sensitive to this metabolite, such as patients with hepatic or renal disease or history of seizures. The dose oral, sub-Q, or IM is 1 to 2.2 milligrams per kilo, not to exceed 100 milligrams. It is supplied in oral tablets at 50 and 100 milligrams. Oral syrup is available at 50 milligrams per 5 ml. And the parenteral solution is available at 25, 50, 75, and 100 milligrams per ml. Fentanyl, or sublimase. It is a synthetic opiate agonist in the same chemical class as meperidine. It is a very potent narcotic analgesic. A dose of 0.1 mg is approximately equivalent to 10 milligrams of morphine or 75 milligrams of meperidine. Fentanyl has a rapid action, and after a submucosal or intramuscular injection, the onset will occur in 7 to 15 minutes. The duration of effects is 1 to 2 hours. It is metabolized by the liver and excreted in the urine. Respiratory depression is the same as with other narcotics. Respiratory rate decreases but returns to near normal quite rapidly. Fentanyl produces little histamine release and has much less emetic effect than morphine or meperidine. It can be administered by IM, IV, or sub-Q routes. When it is used with other CNS depressants, the dose should be reduced. The drug works well when orally administered diazepam and nitrous oxide oxygen. It is not recommended for use in children under 2 years of age. The dose is 0.002 to 0.004 milligrams per kilo. You can find it in 0.05 milligrams per ml in 2 and 5 ml ampoules. So what do we have as a narcotic antagonist? We have naloxone or Norcon. It is a semi-synthetic opiate antagonist used for the purpose of reversing effects of narcotic drugs. Naloxone is a pure antagonist with no agnostic activity, even in large doses. It acts in 2 to 5 minutes after sub-Q or IM injection and 1 to 2 minutes IV. After IV administration, the duration of reversal is about 45 minutes. Adverse reactions include nausea, vomiting, sweating, hypotension, hypertension, VT, and fibrillation, and pulmonary edema. None of these effects has been reported with its use in pediatric conscious sedation. The dose IM, sub-Q IM, is 0.1 milligrams per kilo in subsequent doses to a max of 2 milligrams every 2 to 3 minutes. The parenteral solution dosage is 0.2, 0.02, 0.04, 0.1 milligrams per kilo. It must be mentioned that any time that a patient is sedated or you plan to sedate a patient, you need to monitor the patient with a pulse oximeter or capnograph or a combination of both. An oxy sensor is attached to a digit on the hand or foot or to the earlobe, and it consists of a light emitting diode and light detecting diode. The light emitting diode emits both infrared and red wavelengths of light, and the light is transmitted through the tissue. The wavelengths are absorbed primarily by the oxygen hemoglobin, whereas the infrared wavelengths are absorbed by the deoxygenated hemoglobin. The device calculates the percentage of oxygenation of hemoglobin, and the results are conveyed both audibly and visually. Here are some examples of pulse oximeter, where you use it on the finger, the thumb, the toe, or the earlobe. It is an intraoperative monitoring system that must include, or that does include, assessment of the oxygen level, ventilation, and circulation. The depth of sedation will dictate the degree and frequency of monitoring required. As the treatment progresses, the state of consciousness should be evaluated frequently by verbal communication with the patient. Another area of assessment besides the monitoring device is the patient's appearance. The oral mucosa, the nail beds, the complexion of the skin provide indication of perfusion of the patient. If restraining devices are used that cover the patient's, a hand or foot should be exposed. These devices should be carefully applied to the sedated patient to ensure that there is no restriction of the chest. Heart and respiratory rates can be monitored by using a stethoscope with a custom-fitted earpiece, such as this. This is a something that is molded to the ear, and the round bell portion is put at the top of the sternum. There is a correlation between the percent oxygen saturation of hemoglobin and the oxygen tension in arterial blood. The hypoxemia occurs when oxygen saturation drops to 95%, corresponding to an oxygen tension of 80 mm of mercury. Once the arterial saturation drops to 90%, the patient will begin to desaturate very rapidly. The cells of vital organs will begin to be deprived of oxygen, and the patient's oxygen saturation level should be as close to 100% as possible during the sedation process. A number of conditions can lead to false oximeter readings, including failure to place the diodes directly opposite each other, interference from ambient light, placement of diodes on the same limb as the blood pressure cuff, fingernail polish on the digit, cold limbs, profound tissue pigmentation, reuse of disposable sensors, and motion artifacts. Ventilation must be evaluated independently from oxygenation. Methods used to monitor ventilation include visual monitoring of the chest, listening for breath sounds with a precordial stethoscope, and determination of respiration rate and capnography. Capnography is the measurement of exhaled carbon dioxide used at it's the gold standard for monitoring ventilatory status and will reveal respiratory compromise within 15 seconds. A low exhaled CO2 level may be an indication of hyperventilation, decreased cardiac output, or poor pulmonary perfusion, which can occur in shock. Monitoring limitations you can get inaccurate readings due to head movement, mouth breathing, crying, or tube blockage resulting from and these will all result in inaccurate readings. Here's a picture of one of our capnograph machines and nitrous oxide. We have the patient's mom here putting the face mask on the patient so she's not frightened. And again, monitoring the patient is key. You need to have him hooked up to monitors for the oxygen level. You can see the respiratory and oxygen carbon dioxide exchanges through the capnograph. And most of all, you need a crash cart. In summary, use only drugs and techniques that are thoroughly understood. Indications, contraindications, and how to react and to adverse reactions. You need to know how to manage drug interactions and calculate the proper dosage for each patient. And that concludes our lecture for today. Feel free to send any questions to me via email. Thank you very much.